Rescue Airways, a reflection. When you give only after you're asked, you've already waited too long. Philosophy and practicality meet somewhere above the chords. Today on Supraglottic Airways.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. We have to be comfortable managing airways in children. The truth is, emergent endotracheal intubation is much more common in adults. They're just more likely to become emergently critically ill than children. Now, that doesn't let us off the hook. But then again, endotracheal intubation is not everything. We've talked, you and I, about difficult cases in rapid sequence intubation, and we'll talk some more about the approach to the difficult airway and later the failed pediatric airway. Today, let's use this opportunity to become comfortable with a thought process and a skill that I guarantee will come in handy. Think of supraglottic airways as a brick in the house of airway management that we're building. The foundation of the building should be bag valve mask ventilation. If you can position and clear the airway and bag the patient, you can do anything. But there are times when it's not so easy, or you need backup. Supraglottic airways are a fantastic rescue device. The first rule of Airway Club: learn how to bag. Before anything else, relax. Air goes in and out, blood goes round and round. Stay simple and focused on opening the airway and delivering rescue breaths. How to do this? Before we can deliver positive pressure breaths, we have to align the oral, pharyngeal, and tracheal axes. Now, we hear this a lot. Why is it so important? Think of how you normally breathe. You don't walk around in the sniffing position. You breathe when you're awake, when you're asleep, when you're eating, sitting, standing, hanging upside down. Your axes don't have to be aligned because of one fundamental concept: normal, negative pressure ventilation. Small changes in surface area of your diaphragm will create large changes in pressure between your intrathoracic and external environments. It makes breathing effortless. You almost never have to think about it unless something is wrong. When we care for anyone for whom we need to assist in ventilation, we're using a second-rate mechanism: positive pressure ventilation. Sure, air goes in if we force it, but it can go everywhere. Out the sides of the mask, whirled around the hypopharynx, or even into the gut. Since we're already at a physiologic disadvantage, let's do everything we can to optimize our delivery. Align the oral, pharyngeal, and tracheal axes by placing the patient in the sniffing position. The plane of the face is parallel to the ceiling, and the tragus of the ear is aligned to the sternal notch. Remember that young children have a prominent occiput, and the towel roll under the shoulders can make all of the difference. Shoulder bump for the win. The mask should fit from the bridge of the nose to the cleft of the chin. Bring the face up into the mask. How many times have we seen the opposite happen? In the heat of the moment, the mask is pushed into the face, flexing the neck, obstructing the airway. You can try to ventilate with one hand, as in an EC clamp, and the other you use to bag, but better yet, you, as the airway expert, can focus all of your attention in the tactile and cognitive skill of airway management. Use both hands to seal the mask. Straddle both thumbs on the side of the mask that's facing you. Use your other fingers to hook the bony ridge of the jaw and clamp it up into your double thumb grip. Basically, you're doing a jaw thrust into the mask. Stay clear of the soft tissue under the jaw. A little extra pressure from our big adult fingers can occlude the little airway. Now that you're comfortable and you have a controlled face mask seal, you can coach anyone to bag at an appropriate rate. Make them repeat this mantra back to you. Squeeze, release, release. Squeeze, release, release. This calms everyone, and it delivers about 20 breaths per minute if you pace it properly. Squeeze, release, release. 3 events divided into 60 seconds is 20 breaths per minute, which is a good starting point for a child. Adults need less, about 10 to 12 per minute. Neonates need more. For your littlest patients, say, squeeze, release. Squeeze, release. Use nasal trumpets if needed. By the way, they work great for spontaneously breathing patients as well. You size them from the nares to the tragus. If you're bagging, use an oropharyngeal airway sized from the incisors to the angle of the jaw. Remember, if you can bag and suction, you can do anything. Proper bag mask ventilation saves lives, not fancy advanced airway procedures. Nine-month-old Emily is brought in by ambulance for difficulty breathing. She was discharged yesterday with a diagnosis of bronchiolitis, and she's been increasingly short of breath today. On arrival, her heart rate is 180, respiratory rate 60, oxygen saturation 84%. She's pale. She's limp and poorly responsive. Just transferring her over to the gurney, her heart rate drops to 80. You can see her turning gray in front of you. Without hesitation, you place a shoulder bump, choose a mask that fits from the bridge of the nose to the cleft of the chin, and bring her face up into the mask as you deliver deliberate breaths, just enough for chest rise. Initially, you try to sync with her, but she abruptly becomes apneic and allows you to bag her. Squeeze, release, release. Squeeze, release, release. The phrase is tranquil. The room calms with your mantra, and you avoid bagging poor Emily at your own pulse rate. While you coordinate the rest of her care, you can see that intermittently she has some resistance to bagging. You recheck your position, making sure her head and neck are midline, and think, maybe that large tongue is getting in the way. You place an oropharyngeal airway, and things seem to become easier. Emily's mother then rushes in, panicked. "My baby! Please don't put another tube down her throat!" You look up to see a tearful, desperate woman. She goes on. Emily was a preemie, and she's been intubated 3 times. The last one was a nightmare. You ask Mom when that was. 2 days ago. It turns out there's more to the history than what was available initially. You think, Emily is at risk for subglottic stenosis, and she probably still has some airway edema from her last intubation. You're still wondering why she was sent home so early, but no time for that. You have to make a decision. Emily remains apneic with bagging. The good news is that her heart rate has normalized. It's in the 140s now, and her oxygenation is in the mid-90s with bagging. So, you could just go on to rapid sequence intubation, and there's nothing wrong with that. But you already know that this is a difficult airway, and you've already made some real progress in stabilizing her. You have a moment now to ask yourself, why not go straight to a supraglottic device? All roads lead to Rome, or so they say. There are many options here, but think of one that we sometimes forget about. Supraglottic Airways are not definitive, but they're reliable and fast. According to a meta-analysis of pre-hospital airway control techniques by Hubble et al., the laryngeal mask airway was easier and faster to place than an endotracheal tube. The ET tube mean placement time was 88.3 seconds. Compare that to 38.6 seconds for placement of an LMA. Okay, but what about the security of having an endotracheal tube in? Is it even safe to move the child to the operating room for a more controlled environment? Or what if I have to transport her? Is it safe to have just a supraglottic device in? Carlson et al. In Pre-Hospital Care report the results of a cadaver study named very appropriately, How Much Force is Required to Dislodge an Alternate Airway. It turns out it takes about 14.4 pounds of vertical force to dislodge an endotracheal tube. It takes much more force to pull out an LMA, 18.3 pounds of vertical force. So, a well-secured supraglottic device compares very well to a well-secured endotracheal tube. The point here is that, all things being equal, a fast, reliably placed supraglottic device is a nice alternative when an emergency definitive airway may not have a good risk-to-benefit ratio. There are all sorts of manufactured supraglottic devices, some newer than others and some more studied than others. We'll go over some of the more readily available devices with preference on those for which we have some evidence basis. What you have available will vary depending on your local EMS agency and hospital, but let's go over some of the more commonly used devices to answer all of the questions we just never seem to have the time to ask. The laryngeal mask airway, the LMA. The LMA is the first supraglottic airway device invented by British physician Archie Brain. What a great name for a great man. Not surprisingly, the LMA is widely available and it is the most widely studied in adults as well as in children. Pediatric LMAs start at size 1 for a neonate and infant less than 5 kilos, and they go up by half sizes until we get to size 3 for a child from 30 to 50 kilos. Now, you can see that there's a pretty wide range there. The point is that the cuff is designed to seal as it inflates. After 50 kilos, LMAs graduate by whole sizes from a size 4, or 50 to 70 kilograms, to a size 6 for those greater than 100 kilograms. Although the LMA was first designed based on adult cadaver molds, it turns out that the same basic design, with a few modifications over the years, fits children as well. The secret is in the inflatable cuff that molds to the individual's hypopharynx. Think of the LMA as an internal mask. Instead of trying to get a good seal externally around the mouth and around the nose, the mask of the LMA sits in the hypopharynx, inflated to fit snugly and offer a reasonable seal. The aperture bars at the opening prevent the epiglottis from flopping into the ventilation tube. You size the LMA by weight. Don't bother memorizing the sizes. Just look for the black lettering on the side of the tube to know what weight to use for what child, adolescent, or adult. Use ideal body weight whenever possible to size the LMA. Make sure the cuff works first by inflating it, then deflate it until the cuff is flat, not wrinkled. This makes for a smoother passage. This way, the LMA will be more likely to slide posterior to the epiglottis. We want to avoid an overly stiff and wrinkled cuff from angling anteriorly into the vallecula, and then when you inflate it, the epiglottis can be deflected down, obscuring the airway. After deflating it flat but smooth and without wrinkles, lubricate the cuff. I like to think of placing the LMA like a more hands-on version of direct laryngoscopy. Scissor the mouth open with your right hand. Think of your left hand, the one the laryngoscope would be in, as your facilitator. Grasp the mentum of the jaw with your left hand. Alternately, you can use your left hand to cradle the occiput and extend the head to open the airway. Hold the LMA in your right hand like a pencil. Thumb at the base, index and ring fingers opposite. The black line on the tube should face you, back to black. The opening of the LMA is facing the patient's airway and away from you. Insert the LMA, letting the deflated cuff run along the hard palate. Keeping the tongue away by lifting the chin with your left hand, your right ring finger pushes on the junction between the mask and the tube to seat the LMA, with the distal tip sitting just posterior to the cricoid cartilages, and the proximal portion will seat against the base of the tongue. This points the ventilation right into the glottis. You inflate the cuff, and you'll see an expected slight rise. Like fresh bread in the oven, it's a welcome, comforting sign. The LMA has a good success rate. One in-hospital study showed a 90% success in the first attempt and an additional 8% success on the second attempt. In this prospective study of 1,400 children by Lopez Gil et al. In anesthesia, only 2% required an alternative technique. Neonates had an even better first-pass success rate, 98.5% by another study by Zhu et al. In resuscitation. There's good data on the use of LMA in preterm infants as well, all the way down to 800 grams. Also, LMAs can be used successfully in those with premature lung disease and even those with abnormal facies, such as the Pierre-Robin sequence. The 15mm adapter will fit on your self-inflating bag or any standard ventilator circuit. Secure the LMA just as you would an ET tube. I prefer to use the Lillehei taping technique. Make sure the child is well sedated and paralyzed if needed. Aspiration in LMAs is rare. It's estimated to be about 1 in 5,000. The goal is to have a reasonable seal and to be able to ventilate to chest rise. If you suspect a leak, here's how to check for it. Listen first for an audible leak from the mouth. If you don't hear that but you're still suspecting a leak, then you can use your stethoscope to auscultate at the thyroid cartilage. There are other fancier ways to do it in the OR, including intraoral capnography, but let's stick to what we have. If you detect a cuff leak, recheck the patient's positioning first. Then consider adjusting the inflation. You can use a tracheal cuff pressure gauge to measure the LMA cuff pressure. It should be no greater than 60 centimeters of water. Remember, for ET tube cuffs, we aim for lower, for 20 to 25 centimeters of water. For the endotracheal tube, the goal is just to hold the tube gently in the non-distendable trachea, just under the cords. For an LMA, though, we want a good seating in the pliable hypopharynx. Speaking of differences, regardless of how you feel about cricoid pressure for endotracheal intubation, please don't use cricoid pressure when placing an LMA. You're more likely to place it improperly than you are to prevent any microaspiration. Just to be complete, there is an intubating version of the LMA. You know, the one with the frying pan handle and the reinforced tube and stylet. But it only comes in 3 sizes. 1 for children in general and 2 for adults. It doesn't accommodate neonates or infants, And truthfully, the intubating LMA requires a completely different skill set. It's complicated and infrequently needed, and not all sizes are available. I can't recommend its routine use for children. The King Airway. The King Airway, more formally called the Laryngeal Tube, was first introduced as a simpler version of the confusing combi tube, which, by the way, is not used in children. The laryngeal tube consists of two cuffs. The smaller distal cuff obscures the esophagus to prevent gastric insufflation. The larger proximal cuff balloons out to seal off the oropharynx. The advantage of the King laryngeal airway is that both cuffs are inflated by the same port simultaneously. When above and below the glottis is sealed off by the cuffs, positive pressure breaths are delivered through a port between them and into the trachea. The advantage of the laryngeal tube is that it's designed to be successful even with minimal to no training. In one study of 500 mannequin intubations, the laryngeal tube was placed appropriately 100% of the time. Similar results were found in a study of Finnish military responders after watching a short video. One study in the US even looked at the worst of circumstances. Over the telephone, completely inexperienced undergraduate volunteers were talked through placement of the laryngeal tube in a mannequin. Without supervision, even they placed the King Airway 80% of the time. In a pre-hospital pilot study in actual patients, EMS placed the laryngeal tube 100% of the time. There are a few caveats with the laryngeal tube. It is a little temperamental in terms of position. When there are more than 45 degrees of flexion of the tube, it'll leak. Also, the King Airway is available only down to a size that fits a 12-kilogram patient, which means it can't be used for infants and most toddlers. The King Airway, though, is a viable option, especially in the pre-hospital setting. The AirQ. The Cook Gas AirQ is a newer supraglottic device that has a few advantages over the LMA. Since the intubating LMA is not really designed for children, there was an opening in the market for a supraglottic device that could be used to place an ET tube if needed. Enter the AirQ. Unlike the LMA, the AirQ has no aperture bars and it has a wider ventilating lumen. It can be used just like the LMA, but the AirQ also has a removable connector as well as a more rigid tube, which allows for the passage of an endotracheal tube through the lumen of the AirQ to facilitate a more definitive airway if needed. The AirQ is available in a full range of pediatric sizes and has been used successfully in children with syndromic airways. Think of the AirQ as a pediatric alternative to the intubating LMA. The EyeGel. The new kid on the block, the EyeGel, takes a departure from other supraglottic devices that rely on pressure cuffs for a seal. The EyeGel was invented by Dr. Mohammed Nasir, also from the UK. The distal end is made up of a thermoplastic elastomer. When it reaches body temperature, it softens and molds into the hypopharynx. It looks like a green leech from outer space, but it is effective in ventilation when compared to the LMA with better seal pressures in the EyeGel. It's easier to use, and it has one less technical step: no cuff to inflate, or forget to inflate in the heat of the battle. The downside of the EyeGel is that its shape doesn't allow for reliable blind endotracheal intubation through its lumen. To intubate through the EyeGel, you would need to use a fibroscope. The other downside to the EyeGel is that there are no neonatal sizes currently manufactured. Also, since it's a relatively new modality, the only evidence basis we have for its use is in the operating room or in the SIM environment. There are just no large-scale pre-hospital or emergency care studies published to date. All right, now that we have a few options and we know the pros and cons of each, let's run through another case. Tommy is a 20-month-old boy brought in by ambulance for not breathing at a picnic in the park. There was panic on the scene, and the medics have very little info other than he has gasping respirations with stridor. They place him on racemic epinephrine, and they get here as fast as they can. Tommy was sitting upright in respiratory distress, but now on arrival, he's slumping down on the gurney and barely responsive and becoming bradycardic. You go to bag, poor air entry. You reposition, towel roll, oral airway. No real change. Nobody knows nothing. He arrives alone. The medics deciphered what they could on scene, and maybe there was a recent cold, or maybe there's an allergy to something. You think, okay, with his stridor, he could have an edematous airway. Let's place an LMA. In the chaos, you take a moment. You reframe what you have. A toddler who is now gasping for air seems otherwise well with no trauma, and as far as you know, this was all sudden onset. What does he have? You open the airway. Nothing there. Something clicks in your mind. It's the look of desperation on Tommy's face. You get on the gurney, straddle the hips, and place the heels of your hands between the umbilicus and the xiphoid. 5 abdominal thrusts. Later, you hear a choking sound from him. Progress. You go back to the head of the bed. Still nothing obvious that you can visualize. He becomes limp. You go in with your McGill forceps and laryngoscope and fish out a chunk of a full-sized hot dog. You go back in for a relook. Nothing else. You go to bag him. It's easy. You exhale. Okay, now you can place your supraglottic device if you want. But always remember foreign body aspiration, especially in a toddler. Marcus is a 5-year-old boy who arrives to the ED with post-tonsillectomy bleeding. He is obese, in respiratory distress, breathing at 40 times per minute with an oxygen saturation of 96% on non-rebreather mask. You call head and neck surgery stat. He becomes restless and then less responsive. We go to take over his airway. Suctioning through the clots, you see a Cormac-Lehane grade 2 view. The supraglottis then pools with blood. You've just lost your view. You try again, this time with a new blade. The same. You decide to go for the AirQ. You place it. He ventilates. The room softens. The surgical team arrives, and they take him immediately up to the OR. They were able to use your good supraglottic airway to intubate through the AirQ and establish a nice, secured, and reinforced tube for oropharyngeal emergency surgery. More formally, there are 3 advantages to the supraglottic airway and 2 main indications. The advantages are that it's simple, it's fast, and it's reliable. If you don't need to deal with a foreign body, it is perfectly fine to use a supraglottic airway as a primary approach for the anticipated difficult airway. According to the Difficult Airway Society, use a supraglottic airway for either a difficult mask ventilation, like the one we talked about earlier, or for an unanticipated difficult airway. Now, granted, these are guidelines that are OR-based, but we can modify them for our purposes outside of the operating room. In a difficult mask ventilation, first reposition. Make sure the head and neck are midline. Put in that shoulder bump and ensure the sniffing position. If that doesn't work, add an oral airway. Get more hands on deck and use both of your hands, thumbs down, fingers along the bony ridge to bring the face up into the mask. If there's still difficulty despite optimizing mask ventilation, place the LMA. Sedate and paralyze as needed. In an unanticipated difficult airway, the trick is not becoming too task-focused. You take a reasonable number of attempts, each time changing something. The blade, the tube, the position, the intubator, maybe even using video laryngoscopy. At some point, when you least expect it, you seem to be getting nowhere and you're in that moment. You know what I'm talking about. The moment when blood drains from your face and chest only to be met with a rising sense of dread, mixing in a nightmarish coagulated mess in your heart. Don't give in to this. There is a way. It just doesn't include continuing to do what you're doing. It's not working. Place the supraglottic device. Place it early and often. It's not a failure. It's a win for you and your little patient. In summary, if you can bag the patient, you're winning. If you have difficulty bagging or you anticipate a difficult airway, then don't forget your friend, the supraglottic airway. Ego is the enemy of safety here. LMAs are simple, fast, and reliable. Think of them as the intraosseous device of the airway. When have you ever felt ashamed about placing an IO? You place an IO because you take charge. You see the flailing and failed IV access attempts. You go for it. That is how we should see the LMA. It's a rescue device, and it can save you and your little patient. You just have to be open to the option. Thank you for listening. I really appreciate your support and your feedback. Until next time, remember, you are the champion and the airway guardian for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.